going to take a look at diabetes. Diabetes is actually in med-surg too. Why do we cover it now? Why do we cover it now? Tell me, Aaliyah. Why would we cover it now? It does. Direct application to fluid and electrolytes. What's another reason? Nadia. Do you ever see diabetes in the clinical setting? You do, a lot. And so we did not want you to wait till 7th semester to find out about diabetes. So you will have more content, but that's why we go ahead and start it now. But the bulk of your study should be on renal. So 3 to 5 questions, as Jen mentioned, on diabetes. The other thing, too, is notice the asterisk slides. Those are the testable content. So it's not all of them. Diabetes is a complex chronic disorder. So you have problems with metabolism. It's disorders of carbohydrate, fat, and protein metabolism. And then we have abnormalities. The organs mainly affected: heart, kidneys, eyes. Also, complications from what in the world is microangiopathy? Break the word down. What's it mean? Brenda, help me out. What's micro? Small. Angie. Vessel. Apathy. Disease. Disease is small vessels, like in your feet, in your skin, in your kidneys, in your eyes. That's why people don't heal well. Also, macroangiopathy. Large vessels leading to the kidneys. Stenosis of renal arteries. Heart disease. Stroke because of the cerebral arteries. Our large vessel that goes down to our foot. We don't get perfusion. You get a wound on your foot, doesn't heal, amputation. First infection, then amputation. That's how that happens. It is all, and then neuropathy. What happens in the nerve cells is that with increased glucose, you have an absorption of glucose in the nerve cell, and it breaks the nerve cell so that you have numbness. How long do people have diabetes? Give me numbers. Give me numbers. What kind of numbers of years do they have diabetes?
20 years.
20 years, 30 years, 40 years. Pop, 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 over time with hyperglycemia, and then you can't feel your feet anymore. That doesn't happen on day 2. That doesn't happen in year 1. But hyperglycemia causes glucose to be absorbed into the nerve cell, and then you'll have a rupture. You don't repair the nerve cells, which is why you start having neuropathy. We've had problems with folks not being able to have innervation in their stomach and empty their stomach because of complications with the diabetes. Insulin, starred slide. The hormone which lowers blood sugar levels. What raises blood sugar levels? Help me out, Michaela. One hormone that raises blood sugar levels. Glycogen is actually stored glucose. Glucagon. We got a lot of G words going on now. Remember we had some O words, had some A hormones, now we got some G words. So glycogen is stored glucose. Glucagon raises your blood sugar. From where? From where? Insulin comes from beta cells. Glucagon comes from your alpha cells. They're next door neighbors. They raise and lower and keep our blood sugar in balance. Anything else? Someone with a knife. Well, if that really worked, what would happen? Okay, no. Think about your physiological response. That's what I'm after. What would be produced? Adrenaline, epinephrine, norepinephrine. Emergency situations, raises your blood sugar. Why does that make sense? Help me out, Hallie. Because the fight or flight. You need to have activated glucose to energize muscles because you're going to fight or you're going to run. Exactly. Plus you need to think. Growth hormone increases blood sugar levels. That makes sense because you have the replication of bone and cells and structures. You need energy. Your body needs energy to replicate all that. So if you're a kid, you may have some unstable blood sugars just related to growth hormone. So we already talked about alpha cells, glucagon, beta cells, insulin. It's the only, insulin is the only hormone that lowers blood sugar level. It is complex. We know it's genetic. It can be also autoimmune, or thought to be environmental factors. Risk factors, obesity, especially type 2 diabetes is especially prone for obese. Family history. Anybody have a family history of diabetes? Yeah, my cat had it. It runs in our family. I'm glad you got that. Yes. Actually, it did. She did. And I wanted to get a little treadmill, make her exercise. It didn't. I gave her insulin injections for a year. Checked her glucose, too. How do we do that with a cat? Urine samples. Yeah, fresh urine. You hear scratch, scratch. Okay. A little exercise today, sweetie. If you have unusually large babies, it just would suggest that you may later then turn into active diabetes. Gestation is called gestation. And then ethnic populations, African American, Hispanic, Native American, have higher rates. Very common disease. The feature symptom is hyperglycemia. That's what causes the complications. That's what we're going to focus on controlling. So we already talked about that. Blood sugar increases, epinephrine, growth hormone. Uh-oh, what's this one? Also known as your stress hormone. That red's kind of pretty. Okay. And we also know it increases your stress hormone, also increases your hydrochloric acid production in your stomach. You can wind up with an ulcer. Okay. But just know that those also, all four of those, can raise blood sugars. So what makes dealing with diabetes, it can be more complex. Because if I'm a diabetic, I'm taking good care of myself, and I get an infection or I get an injury, what might happen to me? Because of the epinephrine, because of the glucocorticoids with the stress hormone, I may now have increasing blood sugar levels that I've been managing very well at home, and I didn't have any problem. And now I'm sick, or I was in an accident, and now I'm having blood sugar problems. That's why we have what we call sliding scale insulin, to meet those temporary needs. As they stabilize, resume their prior toolkits, they will go back and stabilize. Insulin is known as the storage hormone. It causes glucose to go into storage as glycogen in your liver. The overall function of insulin is to lower blood sugar levels, glucose levels. That's the purpose and function of insulin, to lower your blood sugar level. But it does it in a variety of ways. This is not starred, I'll keep it quick. So, when I eat, My food breaks down. What'd you have for lunch, Michaela? What time? Oh, Daddy beef. Okay. So your body is now breaking it down. Blood sugar's rising. Insulin is going and taking that glucose and putting it into storage as glycogen. Okay. So it increases glycogen formation. That's called glycogenesis, the formation of glycogen. Okay. So it doesn't break it down, it puts it into storage. It also helps then in terms of the storage of fat and protein. It doesn't abnormally break down fat and protein, it puts it into storage, what it's supposed to do. So it increases the formation of fat, doesn't have abnormal breakdown. It also promotes protein synthesis. But if I don't have insulin, I don't have glucose, and one of the things when we talk about the storage hormone, in order for glucose to be used by a cell, what has to happen? Anybody know? In order for glucose to get into a cell membrane and be utilized, you have to have insulin. Insulin goes and hits the cellular code and allows for glucose. So insulin is your Mack truck driving around your load of glucose. Insulin hits the code of the cell, makes a delivery of glucose, drives down, hits the cellular code, and makes your delivery. If you don't have insulin, you have high blood sugar, but it isn't going into the cells where it needs to be used. So you have cellular starvation. If I don't have insulin, I have hyperglycemia. It's not going into the cell and being utilized. It's not being stored as glycogen. Because you have cellular starvation, your body will start breaking down its fat stores in an abnormal way, causing ketones. Anybody knows what ketones can do? If they are acid in nature, what will develop? Acidosis. It's actually called DKA, Diabetic Ketoacidosis, a complication. And then you can have protein metabolism. Well, instead of being stored, insulin's not there, it doesn't get stored. Types. The IDDM, typically a younger person, that means there's no pancreatic function. No beta cell activity. What must they have to survive? Insulin injected in. You don't have that, you will eventually emaciate and die. That's how that's what used to happen before we had insulin, is they were from a concentration camp. Because they had plenty of glucose, it couldn't get into the cell. So they had cellular starvation. NIDDM. Folks, this is the most common. There is poor beta cell. But there is still beta cell activity. So it's inadequate quality or quantity. 50% of those folk, if they had very rigorous dietary and exercise management, would be able to control it with dietary and exercise. If that's not sufficient, they can use an oral hypoglycemic, a med. If that's not sufficient, you may see insulin added on, injectable. Okay. But this is where you do have beta cell activity, so we want to utilize that. Gestational, that's when it's in pregnancy. Secondary, anybody know? That'd be like pancreatitis. Okay. Your beta cells in your pancreas, you get an inflamed pancreas, or you get cancer in the pancreas, you can't produce insulin. And so we won't really talk about that. We'll really talk about IDDM and my DDM. Type 1, you have no beta cell activity. If you don't have insulin, you will eventually die. Prone to ketosis. You have cellular starvation. The body starts screaming for cells. So the body starts breaking down fats. That's where you get your ketones, which are acidic. Problematic. Usually occurs in younger people. Anybody seen kiddos with type 1 diabetes? Ooh, how old?
She's 13.
Okay, 6 months. 2 months. Type 1 diabetics. Typically genetic. Thought to be from autoimmune and genetic predisposition. NIDDM. These folk are not dependent on insulin. They can use an oral hypoglycemic. Anybody know how an oral hypoglycemic works? It stimulates the beta cells to produce a better quality or quantity. So if you don't have beta cell activity, that won't work. That's why type 1 diabetics do not improve on oral hypoglycemics. The glucophages of the world. They won't get better until they get injectable insulin. Type 2 has beta cell activity. Insufficient quality, quantity. So they may wind up using insulin, but they'll try a lot of other measures first. Diet and exercise. Then we go to oral hypoglycemics. And if that's still not managing, then we'll go to insulin. So it's not necessary to preserve their life, but you may see them treated with it. We're seeing NIDDM. You know, years ago, you never saw NIDDM was for seniors. Why do we have NIDDM in kiddos now? That's been astonishing over my lifetime.
Processed foods. Processed foods.
A lot of thumb activity versus running around outside. Yeah. Dietary exercise. Absolutely. Highly tied with NIDDM. Okay, a strong genetic influence and a very strong, folks, lifestyle. Painful lifestyle. That's secondary. Pancreatic, drug, alcohol, impaired glucose tolerance. So type 1. Always your classic symptom for diabetes is going to be hyperglycemia. That then starts a cascade of events. Always. Hyperglycemia is your initial symptom. Hyperglycemia. Why would you, let's see, I see that's, okay, we'll go to another one that is starting. So, you're going to see glucosuria. Why would you see glucosuria? We'll go ahead and quickly go through this.
Because your body's trying to get rid of excess amounts of glucose.
That's exactly right. We don't eliminate glucose. We recycle it. But once your body gets to 160 to 180 milligrams percent, it becomes a waste product. Your urinary system then excretes it. That is called glucosuria. That's abnormal. You shouldn't be having glucosuria. Why would you see polyuria next? This is a sequence of events. You need to know the sequence. Why would you expect to see polyuria next? Help me out, Kiana. Why does polyuria follow glucosuria? What's the patho? Correct.
Is it because it's trying to keep your body?
What's the nature of sodium, protein,
Water
and glucose?
follows the
It
glucose.
follows what? It draws fluid. So those three elements have an osmotic pull on fluid. So if I have it in my urine, what's it going to do? Pull more urine. Polyuria. Polydipsia, what's that mean?
Dry mouth.
Thirst. Why am I thirsty? Because I'm losing. I get dehydrated. classic symptoms. These are called the 3 Ps. Polyuria, polydipsia, polyphagia. What's the phagia? Hunger, because I have cellular starvation. Glucose isn't getting into my cells. I'm losing weight. This is not a good way to do it. Weakness, weight loss, lethargy, ketosis. This will lead to diabetic ketoacidosis. So, the complication is diabetic ketoacidosis. Fasting blood sugar. Notice with your, and notice this is fasting. This is not following a meal. But typically, they want it to 70 to 126. With a non-fasting, they really don't want your blood sugar greater than 150. They want your body to be responding to that blood sugar level. Okay. So, above 150 is really considered hyperglycemia. They want your pancreas, your beta cells should be responsive to the presence of glucose after a meal. And that's what the glucose tolerance test does. You go in for a baseline blood sugar level, you're fasting. You go in and they get your blood sugar, they see what it is. You drink a concentrated sweet that's kind of sickening actually. And then they check your blood sugar in every hour for 4 hours. And watch how your pancreas responds, how your beta cells. And that's diagnostic. Okay. So, we talked about hyperglycemia is the cardinal symptom. When you hit about 160 to 180 milligrams percent, you're going to get glucosuria. Your body will regard that glucose now as a waste product, which then leads to an increased thirst or increased urinary output, increased thirst. This is related to hunger and starvation with weight loss, lethargy. And then, because the body will start breaking down fats, that's abnormal, and you have acetones, which lead to diabetic ketoacidosis. When do you find out if your kid has diabetes? Sometimes. Huh? Who talk? Oh.
No, well, me personally, we found out that 2 of my cousins had it because they passed out.
Very good. You find out in the ED when you get a call as a parent. They can have a very rapid onset with kiddos. They'll be in a diabetic coma, blood sugar level so high. And what often gets missed is what? I was going to the bathroom a lot and wondered why. I noticed he was going to the bathroom a lot. Going to the bathroom a lot when you're not drinking a lot, something's up. That's how I found out my cat was diabetic. We have 2 kinds of diabetes. Diabetes insipidus, diabetes mellitus. It's like one or the other. Go take her for her blood sugar, diabetic mellitus. Okay. Because it's not normal to be in the bathroom that much. The 3 Ps, polyuria, polydipsia, polyphagia. Type 2 tend to be older. Insidious. Signs and symptoms are insidious. What does that word mean? Gradual. Slow and progressive. They may have symptoms for a number of months, but they kind of adjust to them. They're tired. They'll have blurred vision. It's not like it shoots up to 800. But it can be a slow worsening process. So they adjust to the fatigue and being thirsty and going to the bathroom and blurred vision. They have some pancreatic function, but it's insufficient quality or quantity. So, one of the things that we see is fat and muscle responsiveness to insulin. We have some that's called cellular resistance. And glucophage was one of the first meds that came out that not only stimulated your beta cells in your pancreas to produce a better quality and quantity of insulin, but when it got to the cell, when it hit the code, if it didn't open, glucophage kicked that door open. That dealt with the responsiveness to insulin. That was a big deal. We didn't used to have that. So that's the cellular resistance that you sometimes see. You'll hear the term peripheral vascular resistance, peripheral insulin resistance. Oral hypoglycemics. What type of diabetics can use oral hypoglycemics and get better?
Type 2.
Type 2. Right? If it's type 1, they won't get better. That's how you know they're type 1. We used to be able to determine that by age. That's out the window now. We see type 1, type 2, a variety of ages. Triggers the beta cells to produce better quality quantity of insulin. Also improves the cellular receptor sites to sensitivity for insulin. That's important. And then it regulates your liver. You have little cans of glucose in your liver, your glycogen stores. And so that helps in terms of stabilizing your insulin, your glucose level. So it also triggers that. Okay, diagnostic. So fasting blood sugars, the presence of ketones, if we have any glucosuria in the urine tests, glucose tolerance, talked about drinking that syrupy, checking our blood sugar levels after our baseline every hour, that's actually diagnostic. Looking for ketones, ketosis, ketouria, so ketones in the urine. Don't they first show up in the blood? Yes. Get filtered by the kidney. Your HbA1c. That's your glycosylated hemoglobin. Anybody know what that's for? That's a wonderful, wonderful test. It prevents Pinocchio.
It measures like the last 3 months of your, like the average of the last 3 months of your
It averages your blood sugar over the last 3 months. How is that helpful in terms of working with a diabetic?
Because they can, like they know that if they have an appointment coming up, they could be, not consuming like sodas and candy and stuff like that, but they can see like the last 2 months they were like working.
That used to happen a lot. Diabetics would know that the doctor's appointment for their diabetes is coming up, so the week before, I get on the straight and narrow, I straighten up my eating habits, I start exercising, I get my blood sugar under control, and I show up and I go, I don't know why my feet are going numb. Doc, I do everything I'm supposed to do. Liar, liar, pants on fire. They can't cheat now. It gives you the batting average of the glucose levels over the last 3 months. There's no hiding. There's no hiding. Yeah. Anybody know what the normal level is? It's about 5 to 7%. So we were getting people with 14%. That's non-compliance. Yeah. And you'll see now advertisements. It will help lower your HbA1c. All that is, HgB, your hemoglobin molecule. What happens is that when our blood sugars rise, it puts a sugar coating on a hemoglobin molecule. That's your glycosylated hemoglobin. So what they do is they measure the thickness, and they can determine what kind of blood sugars have you been having. Really helpful for management of diabetics. Proteinuria, microalbuminemia. What does that tell you? What's that saying? Protein in the urine. If I have protein in my urine, what does that suggest? Significant damage to kidneys. If you wait for one of those big protein molecules to plop out to determine if you're doing your diabetic management, you'll already be in advanced renal disease before you figure it out. Creatinine clearance, 24-hour creatinine clearance, or a microalbuminemia test is how you find out if you got good renal function, what kind of damage you got secondary to diabetes. If you wait for those, proteins are a big old molecule, so are bacteria. They stay in the blood system unless there's a significant damage to glomeruli. That's not a good sign to wait for. Doppler? What the heck is a Doppler? Who haven't called on? Mazza, what's a Doppler? Help me out. What do we do? Okay, what kind of problems with blood flow do we have with diabetics? I'm going to get in close so I can hear you. What? Decreased. So, especially in the feet and legs. So you're doing your checks, and when you do your vascular checks on this diabetic, you notice, you wouldn't have your shoe on. I'm not going to take mine off. Okay. So I'm going to check my pedal pulses. Well, I can feel it all the way through my shoe. Kidding. Okay. So I can't feel them. But what do I check? Warmth. What else do we check on? Color. What else? What? Cap refill. But I can't feel my pedal pulses. What can I do? I can go get a Doppler. I am expected to go get a Doppler if I can't palpate. If I can't feel the pedal pulse. Typically it's between big toe and toe number 2, draw a line, and there, flatten your fingers, pedal pulses. If you can't feel those, we have a Doppler machine, you squirt some lubricant, and then you turn on the machine and you can hear the swish swish. That's Doppler pulses. That would be an important assessment finding that should be reported. And then ultrasound fasting blood. For a long time, they have been able to measure your blood sugar levels without doing a finger stick. It's ultrasound. And I'm seeing the technology. 25 years ago, I was at a conference when they already had that. They didn't have a way to market it and make some money. So it's taken a long time to come out. Okay. Fasting blood sugar. If it is with diabetes, we're concerned if it's above 126. So that means I haven't eaten since after midnight. A random fasting blood sugar, so that's non-fasting. If it's 200, remember we don't want it above 150 milligrams percent. We want a responsive pancreas. Or if there's a glucose tolerance test, 200 or above. A treatment nursing care. The overall function, our cardinal symptom, hyperglycemia, overall function for treatment, control the blood sugar level. That's where all your complications come from. Not having tight glycemic control. They did a 10-year study. Years ago, this was a big debate. Doc, I follow everything I'm supposed to do, and I still have all these complications. So, for 10 years, they took a control group. They had this kind of control, this kind of control, this kind of control. Let's compare complications. Hands down. Tight glycemic control decreases complications. It just does. Because that's where all the symptoms come from. Okay, activity. Now, activity directly uses glucose. You don't have to have insulin present to utilize glucose. Exercise your muscles. And what does that tell me about exercise with a diabetic? What does it tell me, Kate? What? You want them to be active. I'm a diabetic. I have high blood sugar levels. If I exercise, the act of exercise will lower my blood sugar level. I don't even have to have insulin for that to happen. That's what I'm saying. That means exercise should be a part of every diabetic's regimen. Faithful daily exercise. Season to season, day to day. Exercise when the glucose is greatest. It will bring it down. What if I take my insulin, my rapid-acting insulin, at the same time that I exercise? You shook your head, Kiana. What will happen? You're going to have a hypoglycemic event. You exercise when your blood sugar is greatest, like after a meal. You do not do it when you inject insulin at the peak times. You'll have a hypoglycemic event. We don't exercise an area recently injected. I don't inject into my abdomen, and then do 50 sit-ups. Regular moderate activities, day to day, across seasons. We don't exercise during the peak times of insulin. We'll have a hypoglycemic event. And then they need to check their blood sugars before and after. They should carry some emergency glucose on them, glucose tabs. So here are the types of insulin. The Lispro, the Humalog, the Novolog. You notice it starts in 5 to 15 minutes. Its greatest lowering effect, its greatest peak effect is 60 minutes. So would you want to, if I gave myself an injection at 8, would I go exercise at 9? Bailey, would I exercise at 9? Why? That's the time you avoid the exercise, isn't it? Because insulin's going to lower it, and my exercise is going to lower it. I'm going to wind up with hypoglycemia. Can you die from hypoglycemia?
Yes.
You can. Can you die from hyperglycemia? You can. It's that balance. Okay. Lasts about 2 to 4 hours. We're using a lot of this in the hospital. Do you know the nursing indication? There's a precaution. Anytime you give Lispro, Humalog, or Novolog, what's the criteria for us as nurses? What? Well, now this onset is 5 to 15 minutes. It's quick acting. What do we need to do as nurses? Food has to be present. Don't inject if the breakfast isn't there, if the meal isn't there. Why?
It's going to drop it.
Because it's so quick acting, they'll be hypoglycemic before I can go get a tray. The food has to be present. Our short-acting regular insulin, for many years, it's a half to an hour. We would do it 30 minutes early and then make sure the tray showed up. Different with Lispro. Tray has to be there. Very good, Sarah. These are both clear. In pH, look how long that the duration. And how is its appearance different with NPH? Anybody know? Cloudy. I have to roll it to put it in suspension, or I can rotate. You don't vigorously shake, it adds air bubbles. But you have your vial, and you roll it to, it's like Milk-A-Mag. It separates out, so you have to just rotate it to put it back to mix it. Long-acting Lantus. You can't mix it. It's typically given. It's a 24-hour. And the one thing about there is no peak. You give it, it has its effect, and it stops. That's very different than this that kind of goes up and goes down. That's a peak. This has no peak. That's been out for about 15 years now. Initially, I was seeing one time a day, and then I began to see twice a day. 9 in the morning, 9 at night, or 8 in the morning, 8 at night. So you'll see different modes of treatment. The whole purpose is to work with exercise and diet to have good blood sugar control. Dietary guidelines. Peak times of insulin. We give them snacks to anticipate that lowering of blood sugar level during the peak times. We don't want them to be hypoglycemic at 11 o'clock in the morning, or at 3 o'clock in the afternoon, or at 7 o'clock in the evening, or at 3 a.m. That's why we provide snacks. It comes out of their whole planning dietary guide. Goal is ideal weight. Oh boy, culture, economics, food preferences really impact food choices. It can be very difficult for a diabetic to manage. You do want, it doesn't have that. Increased fiber, just off the cuff. Anybody know why we increase fiber? 30 grams a day. Anybody know?
Regular bowel movements. Full of the
Slows absorption of glucose in the intestinal tract. And then with diet, we don't want you to have all your fats for breakfast, all your proteins for lunch, and all your carbs for supper. It should be what's called a mixed meal. Protein, fat, carbohydrate, breakfast, lunch, supper. Alcohol recommendations. What was that stuff we had, that Frenchy stuff? Hard liquor. What was it? Help me out. Do what? Douce. I got some Douce. What's it going to do to my blood sugar? I'm a diabetic. It's been a hard week. I'm stressed. I don't know how to cope. What's it going to do to my blood sugar? Well, it's going to keep it the same, elevate it, or decrease it. What's your vote? Who says it's going to elevate my blood sugar? You're wrong. Hard liquor drops your blood sugar. The diabetologist nurse that I went to a conference, she really explained it well. She said, normally your liver is involved in taking its glycogen stores, breaking it down to glucose to maintain that blood sugar level. When the booze comes on board, it's so busy breaking down the booze that it can't get to the breaking down the glycogen, so they get a hypoglycemia. Now, I can't tell you if you start having the Tom Collinses, the sugary dessert drinks, that I don't know about that. But hard liquor, straight hard liquor, will drop your blood sugar. Now, what's the recommendations for booze? None. You're diabetic. But if you must, one with a mixed meal. That means not one of these, a vodka, you do say. But that means an ounce of hard or beer with a meal. But prefer none. Concentrated sweets, pies, cookies, fudge. What's your favorite dessert, Michaela? If you imagined a dessert, what would you imagine? A cake. Okay. Thick icing. What do they recommend about concentrated sweets? It's your birthday, for heaven's sakes. I don't know if that's really true. What do they recommend?
Sugar-free.
They recommend no concentrated sweets. However, it's a kid, and it's his birthday. So what they recommend is that small portion. You have to take off of a meal some of your protein, some of your fat, some of your carbohydrate, have a very small piece with a mixed meal. Then it's allowed. FYI. Hard to live with this, right? The goal maintain a near normal blood glucose level and your lipid levels. We already talked about that. Ooh, what do I do if the client is NPO? If I give them insulin, let's say insulin is scheduled for 7:30, but they're NPO this morning. They called and ordered their breakfast yesterday at 7:30, but today they're NPO. Do I give the insulin? Do I not? Pardon? Normally we need to find out from the physician. Because what's your blood sugar going to do? It's going to go down. What's my food going to do? Not be there. So that would be, we need to clarify that with orders. And then TPN. What do we do? What's normal protocol with TPN? We check blood sugar 4 times a day. Well, are they diabetic? Is this person suddenly becoming diabetic? No. They have such a heavy glucose load. Remember, there's about 2,000 calories in a liter of TPN. That's a heavy glucose load. Your pancreas may not be able to manage. And so we have to go sliding scale. I'm looking at our time. We're going to slide forward. Medication, we already talked about this. Okay. Do remember, they have pre-mixed if they're on regular and NPH, it already comes pre-mixed, 70-30, 70-25. We have to rotate it. Anytime there's NPH, we're going to have to rotate it. Insulin syringes. The only thing you put in an insulin syringe is insulin. You don't use other syringes for insulin. Insulin syringe, orange top, insulin, period. It's units, not in mLs. Big deal. Cloudy, we have to rotate. Give it a 90-degree angle. Fine. These are oral hypoglycemics. That's not starred. Complications. Low blood pressure, low blood sugar. Somogy phenomena is when you have a rebound 3 a.m. Hyperglycemia. I've only seen it happen once. I was giving a report, and they were talking about the doc had ordered a 3 a.m. blood sugar, and it's like, why would they do that? It's like, Somogy! Dawn phenomena is where your glucose corticoids, your steroids, cause your blood sugar to rise. I need to move on. Hypoglycemia, too much insulin, too little glucose. I get my insulin, don't have food. Or I have blurred vision and I drew up too much insulin. So you have sympathetic activity, your epinephrine starts. Think about when you've gone too long without eating. You get a little shaky, you get a little hungry, you get, what's that word? Hangry? Irritable? Those are your early symptoms. Weakness, fatigue. You get a headache related to going too long without eating. That happens. You get sweating, cold, clammy. That's a sympathetic response. Dizzy, confusion, blurred vision, coma, death. Hypoglycemia can result in death. If you are working the night shift, signs and symptoms of low blood sugar and you're diabetic is they're walking in their sleep. They're having nightmares. They are crying during their sleep. Those are symptoms of low blood sugar, folks. Heads up. Need to know that. So we're going to provide glucose. Hyperglycemia, trying to cover the cause. Ketoacidosis, that's when we get an acidosis. Diabetic ketoacidosis. It's that hyperglycemia, polyuria, polydipsia, aphasia. Abnormal fat breakdown. Get ketosis. Causes a diabetic ketoacidosis. So I have a greater than 250 blood sugar, and they have acidic serum pH, We have the signs and symptoms. They have nausea, vomiting, Kussmaul's respirations. Why do they have Kussmaul's respirations? What's the pattern? Well, why would the ketones cause increased respirations? My body is compensating by blowing off hydrogen ions, deep, rapid, to put me back into balance. Excellent. This is an example of fluid in life. I'm acidotic. I have too many hydrogen ions. What's the first? If I don't have enough buffers to manage, my body will start compensating by increasing my rate and depth of respirations to blow off carbonic acid to put me back into balance. That's what Kussmaul's is. That acetone breath are the ketones. It's kind of, I've heard it described as a juicy fruit smell. It's not alcohol smell. You get hypotension, shock, coma. And then what's the potassium level? What? Well, it's either high, low, or the same. Got a 33 and a third chance of getting this right. They're acidotic. What do we see with acidosis and potassium? What do we see with acidosis and potassium? Well, yeah, when he said, well, you pretty well figure high. Yeah, you have a hyperglycemia. Because you're trying to blow off carbonic acid, and then your kidneys are doing what in 3 days? Excreting hydrogen ion, which then holds potassium back, it accumulates, and you have a hyperkalemia. We'll be doing test review tomorrow. Let's see, I'm going to move along. Treatment, you're going to stabilize them. That's the biggie. They've fluid loss, they're dehydrated. Replacing that, getting the blood sugar down, two primary. Hyperglycemic hyperosmolar. This occurs, folks, diabetic ketoacidosis is associated with type 1. HHS is associated with type 2. People that suffer. This is your hyperglycemia hyperosmolar syndrome. Typically occurs with NIDDM. High mortality rate. What does that mean?
High rate of death.
You're probably going to die if you get this as an NIDDM type 2. Folks, the blood sugar levels are over 1,000 milligrams %. That didn't happen in a day. There's no ketosis. There's no ketones. There's no acidosis. They're like 8 liters short in dehydration. But there's no ketosis because with NIDDM, there's some beta cell activity, enough to keep them going into acidosis. That's the thinking. So you have severe dehydration, enough beta cell activity to prevent the formation of ketones. Look at that blood sugar. Is that not astonishing? No wonder they die. High urine glucose, elevated serum osmolarity, profoundly dehydrated, elevated temp, profound thirst, an increased urinary output. Well, that doesn't make sense. They're dehydrated. What's the urinary output about? Glucose. It's pulling fluid. That's why they're so dehydrated. Confusion, stupor. That means they're not processing. They're very confused. Coma, seizures, no Kussmaul's, and then death. Very common. Rapid recognition. People need to be checking blood sugar levels, but chronic illness is expensive. Equipment and supplies. Correct the fluid status, monitor the potassium, give the insulin. Okay. Try and cover the cause. Okay, complications. Large, small vessels, nerves, eyes, heart, kidney, brain. Common complications of diabetes. You get strokes, you get renal failure, strokes, MIs, when you go to a cardiac unit, 50% of your patients will be diabetics. Renal artery disease leads to end-stage renal disease and peripheral vascular disease. You get small vessel damage in the kidneys. They have more pyelonephritis. A lot of times women find out they're diabetic when they have vaginitis because of the glucose. Easy for an infection to appear. So the pyelonephritis, the glomerular lesions, end-stage renal disease, tubular lesions. Cataracts are more common. Glaucoma is more common. Retinopathy, causing blindness, more common. And then damage to vessels. Lower extremity changes. And then this just goes into foot care. It's a good teaching care plan. And then good travel guidelines too. If you're a diabetic, you know a diabetic, these travel guidelines are very practical, very helpful. And that's it. Why don't we take a break and we're going to come back to schizophrenia.